Mhm. Good evening, everyone. We're here at the New England Division of the American Liver Foundation. We're very excited to have Dr. Caroline Jouhourian from our Medical Advisory Committee present on Nafld Nash, which is a rising health concern here in the United States. I understand that you might have a little trouble viewing the visual that's up behind me, but we did make the PowerPoint available. If you click on the link in the description below this video, you'll be able to download the PowerPoint and follow along. Or you can just listen to our wonderful doctor provide great insights and then save the PowerPoint for later. So with that, I'm going to turn it over to Caroline. Also, you'll see the ability to use a chat. If you have questions as we go through, feel free to send those via chat, and we'll either read them out to Dr. Jouhourian or we will answer them after the video is concluded. So thank you all for being here. And with that, please help us welcome Dr. Jouhourian.
Hi, everyone. As Lindsay said, please feel free to ask questions at any point during the presentation. And if anything needs to be elaborated upon, just ask away. All right. So I am a physician here in Cambridge, Massachusetts, and I'm going to talk about non-alcoholic fatty liver disease. So the objectives of my talk are to first go back and just do the basics. What is the liver? What's its function? Then I'm going to define certain terms, talk about the diagnosis of Nafld, and then the management thereafter. So what is the liver? So it is the largest gland in the body, weighing at 3 pounds. It's also the heaviest internal organ that we have. It's divided into 4 lobes with 7 segments. And honestly, the liver is pretty great. You only need 20% of it to work to actually be healthy. So it's when you have less than 20% of residual function that you start having symptoms of liver disease. It's located in the right upper quadrant, so usually in the right upper side of your abdomen, underneath your diaphragm. And it's one of those organs that you just can't live without. In terms of its function, there's multiple functions. I kind of consider the liver the Swiss Army knife of the body because it gets underappreciated. I think what people always think about the heart, but the liver actually has a lot more functions than the heart. Both organs are very important, but the liver helps detoxify a lot of toxins that come into the body. So patients who have liver disease tend to have a buildup of toxins such as ammonia, which can cause confusion. It is also really important in terms of nutrition and necessary nutrients that we need in the body. So specifically proteins, carbohydrates, and fats. So it helps not only create them, break them down, but it also helps store them. And in doing so, you also need bile to break down fats. And so it creates bile to help digest fats in the small intestine. In terms of making protein, some of the proteins that it's responsible for are the proteins that help in blood clotting. So patients with liver disease can often bleed pretty easily because they can't form clots. Also, in terms of sugar regulation is important in the production and the breakdown of insulin. In terms of medications, a lot of the medications we use get broken down to either an active substance or broken down to smaller substances by the liver. As indicated earlier, it helps stores vitamins and minerals. And then one of the functions that often gets overlooked is the fact that it helps fight off infection. So the liver is a pretty important organ in the immune system. So patients who have liver disease are higher risk for infection. And one of the interesting things about the liver is, unlike the heart or even the kidney, we don't really have any sort of replacement therapy. So we don't have a dialysis for the liver. We haven't been able to create technology that can incorporate all these important functions to really supplement the function of the liver. So I think it's really important to define terms when we talk about liver disease. So there's alcohol-induced liver disease, and unfortunately, the majority of society always thinks that liver disease is secondary to alcohol. But that's actually really not the case at all. It's not the number one cause of liver disease in the world. So in terms of liver disease, I try to look at it as a spectrum of steps. So one of the terms you may hear at times is steatosis. It's actually when we say fatty liver, in the medical world, we use the term steatosis, and that refers to the fact that fat is in the liver itself, so involving at least 5 to 10% of the liver, if not more. And then hepatitis refers to inflammation of the liver. And so it does not refer to actually just viruses. So we often think hepatitis means hepatitis A, B, or C. Hepatitis in the medical world just means inflammation, and we often look at blood work to evaluate for that. And the one thing I want to emphasize is you can have steatosis with hepatitis, and we call that steatohepatitis. And then ongoing inflammation can subsequently lead to some scarring, which initially is termed fibrosis. But if the scarring starts to involve more than 80% of the liver, such that you have less than 20% of its function, then we start calling it cirrhosis. And so where does Nafld, or non-alcoholic fatty liver disease, fall into this picture? So it's referring to fat deposition in the liver that's not secondary to alcohol. And one of the things I want to emphasize is that you can have Nafld with other liver disease as well. So what is Nafld? Like I said, it's the buildup of fat in the liver, not due to alcohol. And then we kind of subdivide that ourselves into two categories. So Nafl, so not NAFLD, but Nafl, which is just fatty deposition. And then if we have fatty deposition plus inflammation, then we call that Nash, or non-alcoholic steatohepatitis. The steatohepatitis referring to the fat buildup with the inflammation. So some interesting things about NAFLD is that initially there's no associated symptoms. So a lot of people are walking around with Nafld and they don't even know it. Really, we start seeing symptoms as the disease gets worse in terms of fibrosis, cirrhosis, but really a lot of patients are without symptoms, or they incidentally are found to have elevated liver function tests. If detected early, so if cirrhosis has not ensued, it actually can be reversed. And it can affect people who drink little, if any, alcohol, and you don't always have to be obese to have Nafld. And I'll get into more about the obesity factor in Nafld later on. And as I stated earlier, it can lead to cirrhosis. So this is really interesting because, as you can tell, to kind of summarize what I've just was saying is that you have a normal liver, then you have fatty liver or steatosis. So once again, that's at least 5 to 10% of the liver has some fat deposition. And that with that, it can lead to inflammation so that you get steatohepatitis. And with the inflammation, you start getting scarring and subsequent cirrhosis. What we do know is about 20% of the steatohepatitis patients, so the Nash patients, develop cirrhosis. So what we try to do is try to identify the patients earlier on so that we can reverse, because up to the fibrosis part, you can actually reverse if you do the proper intervention. It's once we get to the cirrhosis that becomes a little harder, if not feasible. This is a picture of a healthy liver, so it's nice and smooth, no yellowing to it, really kind of a darker red hue to it. And then here you see the fat deposition. So it's the yellow stuff that we see. Fat deposition can be seen through imaging or through liver biopsy. We obviously can't see it. We can't determine that through any sort of other studies. And this is just to compare a healthy liver with a cirrhotic liver. So healthy liver, once again, smooth, normal contour, normal coloring. And then as you get fatty buildup, the yellowing droplets here, and then you get this irregular, lumpy, bumpy sort of texture to the liver, then that's called cirrhosis. And this makes it seem like both livers are the same in size, but with cirrhosis, the liver actually shrinks and gets smaller. So things that I think are really important to know about Nafld is that it's the most common cause of chronic liver disease in the United States, not alcoholic related liver disease, which, like I said, is unfortunately something that people often think about in our society. It's the number one cause of abnormal liver function tests as well in the U.S. The incidence, although we're not quite clear as exactly what the incidence is, we do know it's increasing, and that we know that there's at least 100 million Americans who have Nafld. And of those 100 million, 25 million have Nash, so the inflammation plus the fat deposition. We're also seeing kids nowadays with Nash because of obesity being on the rise. It's currently the fourth most common cause of liver transplant in the United States, and it's projected to be the leading cause by 2025. Type 2 diabetes is a risk factor, and we often see a lot of these patients with Nafld. and that all obese patients tend to have some form of Nafld or Nash as well. So the incidence really parallels the incidence of obesity. This figure, it's a little outdated, but it's looking at people who are on the wait list for liver transplant. And it ends in 2013, so we're 6 years out from this. But as you can tell, so Hep C probably has really plummeted down with the treatments that we have because we have cures now. But back in 2013, it was the #1 cause of liver transplant. But if you look at the slope or how fast this is rising, which is the Nash, it's really actually going up pretty fast. And I'm sure right now it's even going up probably almost at a 90-degree angle. So Nafld, unfortunately, is underdiagnosed, and we're trying to work on that. It's kind of considered to, people are starting to look at it as probably a crisis in our society. And then here you have the dotted line, which is the autoimmune liver diseases, which is steadily going up, but not the same rate that Nash is. And then down here you have hepatitis C with autoimmune liver disease, and it's kind of held steady over the course of time. And then here it's looking at the demographics associated with Nafld, and usually seen in patients 40 or over, and more common in men than females. So projections for 2020. So NAFLD, so just the fatty deposition, is projected to be in at least 30% of adults and 13% of children. And then NASH is thought to be, will be probably found in 3 to 4% of all adults, 15 to 20% of obese adults, and 25 to 70% of patients who want to undergo weight loss reduction surgery, so bariatric surgery patients. So some of the risk factors for Nafld, so as indicated earlier, being of middle age, so 40 or above, male gender, Hispanic ethnicity, rapid weight loss is another risk factor, being overweight or obese, type 2 diabetes, having high cholesterol or high triglyceride levels, and then certain drugs such as tamoxifen, amiodarone, steroids, and other some antidepressants and whatnot can be risk factors.
Could you speak briefly on the higher rates in people who are of Hispanic descent?
So the diet, and this is looked at. So the South American diet tends to be high in fatty foods and carbohydrates. So they have a tendency to have more of that, what we call the central obesity, and so as a result, cholesterol tends to be high, heart disease tends to be high, which are all risk factors for non-alcoholic fatty liver disease. And so I'm purposely circling overweight/obesity, diabetes, and cholesterol, because these are the really known risk factors. Everything else is more of an association. So these are really what we have to target in terms of patients with non-alcoholic fatty liver disease. And so I just want to document, because obesity is really one of the biggest risk factors, if not the major one, the trend of obesity in the US. And this stops in 2014. So as you can imagine, and incrementally going up, the rate of obesity is on the rise. So back in 1994, there was a few states that had about an 18 to 20% projected obesity rate. By 2000, there were more than a few states that had over 25% obesity rates. And by 2014, the majority of the United States is considered at least 20% obese, other than Colorado. And I'm sure that's probably changed since then. But we're projecting that by 2016, which we're past that obesity rates will be higher than 20%, which is most likely the case in every state. So I want to define obesity, and this is controversial. It's a calculation of weight and height. And so usually if you go to the doctors, they get your weight, they get their height, and it's documented in your chart. And it's more of a medical term in terms of your BMI, so your body mass index, and these are the numbers. So if your BMI is greater than 25, you're considered overweight, and if it's greater than 30, then we classify you as being obese. And then there's subdivisions within obesity in terms of morbid obesity or mild obesity. BMI, like I said, is a controversial calculation. It fails to look at your body composition, whether or not you have small bones, how much fat versus muscle, because muscle weighs more than fat. So sometimes we think about perhaps looking at the waist circumference more as our marker. So BMI is not a great calculator in certain populations, such as the Asian population. A lot of them may have normal BMIs, but they actually have a lot of central obesity and are at risk for Nafld. And so we tend to also look at the central obesity, and that refers to the waist circumference and how much fat is there. So how do we actually diagnose NAFLD? So we don't have a great test out there. We really kind of have to put everything together. Part of it is history, part of it is your blood work, imaging. So, you may get a CAT scan for abdominal pain, and the liver may say fatty liver or steatosis, which often honestly gets overlooked by a lot of people in the healthcare world. And then one of the important things is we need to actually rule out any sort of other liver disease, because you can have NAFLD and another liver disease. So we often do blood work to rule out other things. Sometimes we have to resort to a liver biopsy. We're trying to move away from that to help us diagnose, but it potentially could be one of the workups that gets pursued. And, if you just have plain old steatosis, which is fatty liver, your liver tests are not going to be elevated. It's when you have the inflammation that your liver tests are going to be elevated. But then once you start getting scarring, your liver can actually mount those liver tests. So your liver test may be normal. So we actually see that liver tests are normal in up to 30% of the patients who have NAFLD. So that's not always the best diagnostic marker. And it's probably why we often underdiagnose NAFLD, and why often patients were termed as having cryptogenic cirrhosis, because they probably went on for a really long time with Nafld, and then eventually developed cirrhosis. And by the time we've diagnosed them, we really don't have a diagnosis for them as to what caused it. So what are some associated symptoms of NAFLD? And these are really symptoms associated with cirrhosis, because NAFLD doesn't have a specific set of symptoms. So like I said earlier, people can go on for decades with NAFLD, not know it until they become cirrhotic, and then they start experiencing some fatigue, start having some fluid buildup in the abdomen, some itching, nausea, some feeling full really fast because of the fluid in the belly, and then confusion. So these are all really non-specific symptoms that you can get from other things as well. So even with those symptoms, you may not get diagnosed with Nafld until you're cirrhotic or have end-stage liver disease. So that leads us to who actually should be screened for Nafld. So unfortunately, right now in society, we do not have formal guidelines. I'm constantly talking to PCPs about, just paying attention. PCPs have a lot to pay attention to, so it's hard, and they don't always get the results from an ED visit or anything of that sort. But I tend to, when I see patients, look at their CAT scans or prior imaging to see if they've had steatosis for some time. But usually what really triggers any sort of workup has been abnormal liver function tests. Like I said, 30% of these patients have normal liver function tests. So, the patients that we kind of have to be a little more cognizant of are those who are obese, those who have high cholesterol, those who have diabetes. Do they have a family history of cirrhosis? Do they have abnormal liver function tests? And do they have some of these symptoms? But like I said, a lot of things can kind of present similarly, and it's not necessarily Nafld. So why do we actually care? Because we want to avoid end-stage liver disease. And with end-stage liver disease or cirrhosis, you're at higher risk for liver cancer. What's really interesting is that these patients with Nash are twice as likely to have heart disease compared to the general public. And about 30% of those patients, actually heart disease takes them, causes their death rather than liver disease. So heart disease is definitely something that, sorry, I'm just going to take a sip of water.
Feel free to ask questions.
Tends to be something that we, and that's something that, do we need to start talking to cardiologists to kind of take a look at these patients and wonder, who needs to be evaluated. Go ahead.
Christopher, I had a liver transplant. I got diabetes because of the medications I'm on. What do I need to look for?
So that's a good question. So patients with liver transplant are at risk for Nafld. Your transplant liver is just as, and so I think, you're lucky in that you probably see a hepatologist. So they're always looking for that. So you're already in the system, and we're on the lookout for that. Some of the, they're looking with the imaging, they look for fatty liver fat deposition. So the problem is a lot of people have fat deposition. And so when do they have to see me versus it's okay to just follow up with their PCP? That's a fine line. And my argument is if they have any questions or if the PCP is uncomfortable, then just send them my way. I'd rather educate the patient to know what to look for, what to do in terms of lifestyle interventions to help reverse that. So, your liver tests are being monitored, you're getting imaging, that's the most you can do. And then just leading a healthy lifestyle, which I'll get into as to what that means. It's hard, especially when food's everywhere. We're getting bombarded with food. So in terms of treatment, so there's actually no formal medication, which our society wants a pill to fix everything, right? We want some sort of intervention. We want a pill. The only thing I can offer is lifestyle modifications, which is really, really hard, especially in this day and age when people are stressed out, working, easier to go and get fast food, eat out. Sometimes eating out is cheaper than even cooking. But lifestyle modifications really is the key to the management of NAFLD. But compliance is really an issue. And in doing so, we're trying to manage risk factors. So the obesity, the diabetes, the high cholesterol. We tell patients to avoid alcohol. Obviously, if you're celebrating a wedding, having a glass of champagne is okay. But why add another factor that could potentially aggravate the situation?
I know a lot of people are concerned about statins. Could
Yes.
you briefly touch on that?
So, statins about 5 to 7 years ago really got a bad reputation because there's some patients who tend to have elevated liver function tests, and that's a result of muscle breakdown from the statins. In fact, we actually encourage statins in these patients because they usually have high cholesterol. It should not be most patients do not have elevated liver function tests on a statin. They may get muscle aches and whatnot. But we actually encourage statins because it helps decrease cholesterol and the fat deposition. So that's something I think we've kind of made a lot of headway with PCPs, but I still think is a concern amongst a lot of patients. So lifestyle modifications, weight loss. So we recommend about 0.5 to 1 kilogram, so 1 to 2 pounds a week, not more, because rapid weight loss can make things worse. And we try to encourage weight loss with a combination of decreased caloric intake plus physical exercise. So one alone is not as good as both combined. We've looked at data, looking at the liver biopsy and seeing changes, and also looking at blood work. And so what we recommend is decreasing your calorie intake by 750 to 1,000 calories per day. Mind you, we always advise to work with a nutritionist. Everyone's caloric intake is different, and not everyone who has NAFLD has obesity. So someone who is not taking many calories and you reduce their caloric intake by 1,000, that may mean they only get 700 calories a day, which is not recommended. So I'm giving this as a hypothetical, but before you kind of hear that, I'd recommend talking to a nutritionist and your doctor. In terms of physical exercise, at least 30 minutes of intense cardiovascular exercise 3 times a week. Ideally, we actually recommend about 260 minutes of intense cardiovascular exercise. And when we say intense, we're saying your heart rate's above 100. We're not saying a leisurely walk around the neighborhood. We're saying you're breaking a sweat. Mind you, some people have physical limitations. So we also advise talking to your doctor about that. But what we do know is actually doing both can reverse fatty deposition, inflammation, and fibrosis. Cirrhosis, like I said, is not reversible. So really, it's hard to get patients to believe that because they don't have symptoms, right? They're not feeling anything. And then, like I said, in society, we get bombarded with food all the time. Food's around commercials, ads, everything is around food. And so it's really hard to have patients make these lifestyle modifications. But what we're realizing is more and more patients are falling into this NAFLD category.
We just got a question online. My father recently passed away while awaiting a liver transplant after having NAFLD. is it hereditary? What test should I request for my PCP, or should I see a specialist?
So I think, so we don't know. I didn't go into what causes NAFLD here. That's something we're exploring. And I think further down the road, we're going to realize there's subsets. And I think there are some genetic components to it. We don't routinely test patients for those things in terms of how fat is broken down in our body, who gets diabetes. So the big thing is that your PCP should be made aware that dad had NAFLD. And so you should be one of those patients that is on the let's check your liver function test at your annual physical, and then maybe getting at some point one ultrasound just to make sure things are okay. Some people may say that's a little overboard, but if dad, didn't take care of his body, was overweight, and you're not, you may not necessarily be in the same category. And if you find that your PCP isn't as comfortable about it, I don't think it's inappropriate to go see a gastroenterologist and talk to them about it. And just to kind of get all your questions answered. Everyone's very different. So I think part of it is also looking at your lifestyle. And like I said, not everyone who has NAFLD is obese. So I want to kind of go over the food pyramid, because I think our idea of eating in society is a little skewed these days. And this was the old food pyramid. And I don't know if you guys remember, but when I was in grade school, I'm probably aging myself, we had to know this. And so, the top of the pyramid was where you had to use the least amount of food. So the fats, oils, and sweets. And then as you got down, you can eat more of that. So bread, cereals, rice, pasta, all of that stuff. And then as of recently, we actually made a change to the food pyramid, and we don't have a food pyramid anymore. We have a plate. And this accounts for a lot of cultural diversity and kind of being a little more specific, I think. So the biggest part of your diet should be your vegetables, and then your grains. Thank you. And then fruits and protein, and then not water, but dairy. So I think this is a better way of looking at things and kind of simplifying, because let's be honest, did you guys remember the food pyramid despite having been tested on it?
Well,
None of us
I
did.
got to eat lots of carbs. So.
So I think this is promoting high fiber diet, vegetables, decreasing the amount of protein. And I think it's nice to look at it as a plate, because the food pyramid didn't tell you they said servings, but none of us really know servings. So looking at something in terms of a plate is an easier way of assessing the quantity in which you could have something. So then in terms of what you should choose more of, so we talked about whole grain food. So whole grain pasta, brown rice, breads, those are better it's also preventative for colon cancer, actually, in terms of being a high fiber diet, instead of white bread or lots of carbs, as Lindsay just talked about. And then in terms of drinks, we, less sugary drinks, more water, reduced sugars, natural juices, avoiding junk food, fast food, and going for the vegetables, the fruits, the homemade meals. So we really are trying to steer away from processed foods. There's a lot we still don't know about processed foods, but I think with time we've gone more towards that, and they're less fulfilling. We tend to eat more, we tend to gain weight. We recommend cooking with unsaturated fats, so not saturated fats, such as butter and lard, but rather olive oil, vegetable oil, soybean oil, and nowadays avocado oil. And then instead of taking vitamin and mineral supplements, we actually recommend trying to eat food that's rich and natural in vitamins and minerals, more vegetables and produce. So, like I said, we're trying to get away from the processed foods.
Could I ask another quick question?
Yep.
So somebody once explained saturated versus unsaturated fats to me as saturated are solids at room temperature, whereas unsaturated are liquids. So more the oils are in that unsaturated. I know people were very into coconut oil for a while, but is that a saturated fat or an unsaturated fat?
I don't remember that off the top. So coconut oil was a big fad, and I think
A couple of years ago.
last year it was proven that it's not cardioprotective in any sort of way. And coconut oil was initially used more for like topical use, not I tend to not favor coconut oil. I tend to favor more of the avocado oil. Olive oil is always great. The Mediterranean diet is always a great diet. But really, the point of all these food pyramids is to really kind of going away from these fad diets, ketogenic diets, all these things that, they promote high fat content, and trying to just eat a more well-rounded, less processed diet.
When you're on the keto bandwagon?
Well, you can have it. We recommend it. And you can have it with diverticulosis, guys. You can totally have it with diverticulosis. So, brown rice, I'm kind of regurgitating the same thing, but quinoa, buckwheat, bulgur wheat, oatmeal, oat bran, barley, moving away from, the crackers, the pretzels, the white pasta, the couscous. A lot of people think couscous is healthy. It's not bad, but it's not great either. Pick the raisin bran over the cornflakes, kind of just going back towards high fiber.
White rice, it used to be white rice. They said white rice, not brown rice.
Obviously, and if you have diabetes, certain some of these are higher sugar loads. So it's important we're kind of generalizing, but just be aware that you really need to work with your doctors and your nutritionists. This is not everyone fits in one sort of pot and can follow it. So other nutritional recommendations. So in terms of meat, choosing lean meats rather than red meat, baking and grilling your foods rather than fried foods, and then foods rich in vitamin E. So in certain nuts, almonds have the highest amount of vitamin E, hazelnuts, seeds, sunflower seeds are great, avocados, spinach, fish, so sockeye salmon or white tuna are great. So those are things that are high in vitamin E. Vitamin E is controversial. Before we used to prescribe vitamin E. Like I said, if you're going to take vitamin E tablets, I would say talk to your doctor before you do that. I'm just promoting high vitamin E rich foods. And then in terms of exercise, all forms of exercises can be good for you. So I just say, get out and move. Like some people may have limitations, but swimming, if you're having bad joints, is great. You got to start somewhere, baby steps. So I just tell people, just start moving, do more at night after dinner, go for a brisk walk with a friend, or in the morning, just try to start moving. Because I think once you start leading a healthier lifestyle, starting exercise, it's easier to eat better, because you start respecting your body a little more. And then bariatric surgery, and I'm not getting into many details about it, but I thought it was something that's important because I think bariatric surgery is on the rise, and bariatric surgery refers to any sort of surgery that causes weight loss. So it can be gastric bypass, it can be a gastric sleeve. There's now endoscopic means of doing sort of bariatric interventions. I bring this up because that probably in many people's mind is the easy fix to all of this. One of the things I want to say is that rapid weight loss, which can be seen with bariatric surgery, can actually worsen Nafld. I'm not saying that happens to everyone, but we have to realize that there's different forms of bariatric surgery, some of which cause more rapid weight loss than others. So it's not the end-all be-all for patients who have Nafld. What we do know about bariatric surgery is that patients do better long-term in terms of sustained weight loss rather than lifestyle interventions. And it's okay for people to have ups and downs in weight loss. I think the extremes is what you don't want. So, these fad diets are great for a month or two, and then you get back, or even a few months or half a year, and then you get back to your eating habits and then you gain the weight again. So we want to see more of a sustained weight loss. It's okay to have variability, a little bit of it. It's the extremes that we don't want. But in terms of bariatric surgery, there's been no formal studies looking at the safety in cirrhotic patients, so it's definitely not something we recommend in patients who have cirrhosis. We are starting to look at more studies, seeing whether or not it's effective in Nafld patients. But right now, we don't have any great studies. And so before you kind of pursue this as your fix, I would talk to your gastroenterologist before pursuing bariatric surgery. You kind of have more of a discussion about that. And one of the things I want to say is that obesity is becoming a recognized field in medicine. People are being trained to do that, including myself. And so we're trying to create more of a diverse cohesive group that works with bariatric surgeons and nutritionists, endocrinologists, people who manage diabetes to kind of help prevent the epidemic that's going to ensue with Nafld. So what else can you do? So, when you start having liver disease, I think it's really important to protect yourself from other liver diseases and infections, right? Because the liver is really important in terms of fighting infections. So making sure you have your hepatitis A and B vaccine. Before we never really thought about hepatitis A until recently when we've had a lot of outbreaks and deaths associated. And it's actually not recommended that everyone get a hepatitis A vaccine, but you can go to CVS and get your hepatitis A vaccine.
It's free at hospital.
Oh, they're free at Osco as well. I just found out. And your hepatitis B vaccine. So hepatitis A is a 2-series vaccine. Hepatitis B is a 3-series. You can get them combined. One of the things I always emphasize, and maybe this is, making sure you get screened for it before you get the vaccine. Other things you want to look at is your bone density. So a lot of patients with liver disease have weak bones. And then making sure you're actually following up regularly with your doctor to avoid disease progression. And, some people, it's nice to have support groups. I think, unfortunately, liver disease has been always associated in our society with alcohol. And the reality is Nafld is a bigger cause of liver disease in this country. And we need to start changing that stigma and realizing that this is the cause of liver disease in our society at this time. So. And then if you have more questions or need more information, here are some resources for you. But I can take any questions that the crowd may have.
Anybody here have questions? No? I'm just going to say a few words.
Yeah.
So I just want to remind everyone that the Liver Foundation has a lot of information on Nafld and Nash. We will post some links in the comment section of this video and share those out. Also be aware that we have a Facebook support group that is well moderated by American Liver Foundation staff. So this is a place for people to share experiences, not to necessarily get medical advice, but to kind of find one another. And this video will be available to view beyond today. So with that, we'll say thank you to Dr. Jouhourian.
Thank you.
And please feel free to, if you're watching this after this live streaming, we will come back and answer questions as well. So please feel free to leave your questions and comments in the comment section, and we'll be sure to check it back. All right, thank you.